his wife, who have graciously given to the Department of Medicine the resources to have this very esteemed lectureship, and this is the very first one in history, so history is being made today. But those of you who don't know Barry, and many of the House staff may not yet have had the privilege of interacting with him, Barry usually sits in that seat over there, and he's what we call a lifer. He's somebody that did his undergraduate degree here at the University of Miami. He then went to medical school. He did his MBA here, and then he did his residency at Jackson, the UM Jackson program, and his fellowship in nephrology. So he really is a true king. And in addition to that, things that you might not know about Barry is that he served 2 years in the Air Force. He was a flight physician and clocked in many hundreds of hours and flew at 55,000 feet in a jet that many of us would never get an opportunity to do. He's also well known in the area of medicine for his seminal work in estimating GFR by using various substances, and the concept of using diuresis in patients with ascites in order to improve their hemodynamic outcome. One of the things that you might notice about Barry is that he has sort of a mascot he always brings with him. That's a little frog. Both he and his wife wear those frogs, and I never quite understood what the significance of the frog was. And if you go to his home or you ask him, he'll show you all these this collection of frog statues, pins, whatever. And when I realized what the meaning was, in my mind, and Barry didn't tell me this, but it's really appropriate, because when you think about a frog is able to live in almost any habitat possible. It can live in the water, it can live in land, it just adapts. And anybody that's been a lifer at the University of Miami clearly has to have that attribute of being able to adapt. There are times when there are floods, there are times when there are droughts, there are times when there are good things and times when there may not be a perceived good thing. But overall, he's a survivor. And he survived, and dear to his heart, I know, is the Department of Medicine and our Grand Rounds. And so it's with great pleasure today we honor Dr. and Mrs. Matterson for their contribution and generosity to this very first inaugural Barry Matterson Grand Rounds. And I'm going to give him the honor of introducing the first speaker. Barry.
Wow, thank you, Dr. Weiss. What I need is a copy from Laura for all of our grandchildren. In around 1980s, I was chairing the most complicated VA cooperative study we had ever put together with Ed Fries, and 15 centers around the country. And you've got to have everybody working from the same protocol, same page. You can't have any variation. And all of a sudden, we had a death and a loss of one of the individuals running as principal investigator in the Jackson, Mississippi unit. And you can't just close a unit in a multi-center study. I mean, that's unethical. It's cheating the subjects who have volunteered. So I did a lot of scrambling, made a lot of phone calls, and they told me there's this hotshot guy that we've got who was a junior AOA. He was a fantastic resident, and he happens to be a nice guy. And I called him up and told him what the deal was, and much to my delight, he said yes. And I got the opportunity to meet Bill and his lovely wife, Susan, who, by the way, not only has published 4 books, but has got 2 more in the works. and he joined us, and we've had the pleasure of not only publishing that study in the New England Journal of Medicine, but I think, what was it, 27 other papers that we got out of that? So Bill has been a friend and a colleague, and I hope you give him the warmest University of Miami welcome to these grand rounds.
Thank you, Barry. Let me switch slides here. And that's my first test. So I really want to thank you. I'm extremely honored to be the inaugural lecturer for this series of lectures, the endowed lectures from Barry. And so it was actually 1978 when Barry called me. I know you don't want to admit it was that long ago, but he was very stern and very serious, and I had agreed to take over this study clinic for 6 months. And so he calls and really gives me the riot act, if you will. And I said, I'll do this, and we'll see where we are in 6 months. And I'm still doing the same thing ever since then in terms of clinical trials, especially in hypertension. But I really do want to thank Barry for inviting me. Here are my financial disclosures. Importantly, I need to say that the content does not necessarily represent the official views of the Sprint or Accord steering committees, the NIH, the VA, or the U.S. government, even though many of my colleagues on these studies would agree with what I'm going to be saying. So I want to say that after that initial phone call in 1978, the VA was actually doing a number of cooperative studies very frequently, and many of them were short-term studies, and it was really a lot of fun. That's one of the things that just drew me in to doing clinical trials, was that we would get together often in Chicago or Washington, D.C., and plan studies, sometimes several studies at a time, and Ed Fries was our mentor in all of this, but Barry actually became probably the most significant mentor to me over the years. And we ended up together publishing at least 30 papers or book chapters together, and have not only remained close colleagues, but remained close friends over these many years. And so it really means a lot to me, Barry, to be invited to do this. And I do want to show one of the early meetings, not in Chicago, but so here, my wife and I are over here on the right, when I had a little bit more hair and it was a little bit darker. And of course, here's Barry and his lovely wife, Baruta. I will say that in between us, that's Neil Schulman, and you all know him, even though you probably don't know that you know him, but he wrote the book that Doc Hollywood was based on. So his career took a very different path from ours, in that even though he was involved in large studies like Hypertension Detection follow-up program and other things, he actually became a stand-up comic after that. And I don't think he's returned to medicine from there, even though he does speak to a number of medical groups, and is fascinating. And I did want to show this even closer up picture. I always thought that Barry really looked like Zorro to me. But he was definitely my hero and very important mentor in everything I did. So both of our mentors, and Barry worked with him more closely over many years, was Ed Fries. And Ed, as you may know, in the 1960s, led the first double-blind, multi-institutional controlled clinical trial of cardiovascular drugs in any area, not just in hypertension. The Veterans Administration Cooperative Study on Antihypertensive Drugs. There certainly were a number of VA cooperative studies both before and certainly after that in hypertension, and I'll show at least one other refer to. But let me just briefly describe, and what I want to do this morning or this afternoon is to take you on a little journey to look at what I think are some of the most important National Heart, Lung, and Blood Institute and VA clinical trials in hypertension that really have set the standard for doing hypertension studies, but also provided a lot of the information that we base our practice on when we treat hypertensive patients. And this really was the landmark study that first proved that treating hypertension should be done. Before this, even eminent cardiologists like Paul Dudley White said that you shouldn't lower blood pressure artificially with drugs because it would underperfuse the brain, the kidneys, and what have you. And so many people, including Dr. Fries, felt otherwise, and so designed this study to look at whether cardiovascular disease morbidity and mortality would be lower in hypertensive men. And the reason that it was only in men was because, particularly at that time, there were very, very few women in the VA system that could be recruited from. And basically, in the treated group, they shot for a diastolic blood pressure goal of 90, which has become quite important, quite persistent. And they looked at people with untreated diastolic blood pressures between 90 and 129, compared to placebo in only 523 individuals. Now, I don't know, Barry, whether there was a power calculation done for this study, but I know there were no DSMBs at that time, and basically I think the statistician pretty much made a unilateral decision as to whether to continue or stop the study. But so active treatment was a goal of less than 90 versus placebo, and in both groups, they tried to treat the blood pressures to less than 90 and the placebo, of course, was 3 drugs placebo, but the active drugs were hydrochlorothiazide, 100 milligrams a day, reserpine plus hydralazine. Reserpine is actually a very good drug, but unfortunately, we can't get it in the United States for some years now because nobody is making it, and it still would have a lot of practicality. But you're probably familiar with the results, but may not have seen them in a while, but there was dramatic benefit. So a 96% reduction in cardiovascular events for the 143 patients that were in the upper group, 115 to 129. So the decision was made after a year and a half to stop that group because the benefits were so dramatically different. And you can see that 39% of the patients in the placebo group and only 1.4% in the treatment group had an event over 18 months. And so dramatically beneficial. And then the rest of the study, the 90 to 114 diastolic group, only 380, were continued but stopped early. It was going to be a 5-year study, stopped at 3.3 years. And again, a dramatic 67% risk reduction, highly significant. And if you calculate the number needed to treat, it coincidentally comes out to 2.7 for both groups over the period of time of either 18 months for this group and 3.3 years for this group. And so that really established that we should treat hypertension and that we shouldn't just leave it up there. And again, this trial and over the next several decades, all the focus was on diastolic blood pressure. And we can talk about why that was later. I don't have time to go into it now. But so active treatment clearly reduced fatal and non-fatal endpoints. A subsequent analysis revealed that the benefits were statistically significant for those between 105 and 114, but not those between 90 and 104. Now, I don't think they understood the concept of heterogeneity, which means that my guess is that there was probably no difference statistically between those two groups, even though if you just looked at the milder group, it wasn't independently significant because there were so few people in that group. However, even if there was no heterogeneity, if we'd done a study like this today, to say that we would treat millions and millions of people in this milder group based on 100 or so people, relatively few people, maybe a couple hundred at the most, might be a stretch. And so I'll come back to that in a minute, but certainly after the VA study was done, both within the VA and outside the VA, there was a lot of education going on. The National Heart, Lung, and Blood Institute started the National High Blood Pressure Education Program and sponsored the Joint National Committee report starting in the 1970s, several of which Dr. Matterson and I were actually participants in. But this milder group, even Dr. Fries felt strongly that he had not proven from this study that we should treat all these millions and millions of people in this milder range. And so the National Heart, Lung, and Blood Institute then decided to do the hypertension detection and follow-up program. And the HDFP study was done in both men and women, much larger study, almost 20 times larger, with almost 11,000 participants, 30 to 69 years of age. Again, looking at people with diastolic blood pressures of 90 or above. And they didn't feel that they could ethically do for this broad population a placebo-controlled trial after the VA study had done that, since certainly many of the people in HDFP would also have been similar to people in the VA cooperative study. So they did a randomized study using step care, in the clinics, doing very good treatment and adding drugs to get the diastolics below 90, or referring the other half back to the usual sources of care. And this was way before we had primary care clinics and really good treatment within outpatient settings. Doesn't mean people weren't being treated, but usually for the hypertensive patients, even after the VA study, most of them were either not treated or not treated very well. So it turned out to do what they expected and lead to a difference in blood pressure between the two groups. And the primary endpoint was total mortality. And so here's the entire study. There was a 17% reduction in total mortality, highly significant. And so it clearly answered the question and said, yes, these people are benefited. But what about those in this mildest group? Well, it turned out that they were a fairly large proportion, almost 8,000 of the 11,000, and it turns out that they had even a slightly greater benefit in terms of reduction in mortality of 20%. And so that really did conclusively say, yes, we should even treat people in this, quote, mild hypertension group, the 90 to 104 group. And all the guidelines after that consistently recommended that. I won't show the data, but there was another study done in the 1990s, the HOT study, that looked at whether 80 or 85 diastolic would be better than 90. It may have not been a definitive study, but it was pretty large. It was 19,000 people. They did not show any benefit or harm for 80 or 85. So I don't know that anybody's going to fund a study to look at whether lower diastolics are appropriate or should be aimed for, even though recently guidelines are even recommending a diastolic goal of 80. But realize that we really don't have any definitive data to support that, and the guidelines say that's just an expert opinion to try and go to 80. So HDFP finally provided convincing evidence in 1979 that mild diastolic hypertension should be treated to a goal of less than 90. Guidelines were then beginning to also recommend that we treat systolic blood pressure and treat it to a goal typically of less than 140. But there were no clinical trials that had looked at that and that had tested that until the SHEP study. So the systolic hypertension in the elderly program, done in almost 5,000 individuals, so about 10 times larger than the VA study, with both men and women, 60 years of age and older, who had systolic blood pressures off treatment of 160 to 219 and diastolics of less than 90. It turns out that that's probably not that important because most older individuals with elevated systolics actually have low, quote unquote, normal diastolic blood pressure. It's a very small population that are still above 90. And that's because the arteries get stiffer and you get wider pulse pressures. And as the disease progresses, the diastolic actually goes down. This was a double-blind, placebo-controlled trial, so active therapy versus placebo. The main therapy was chlorothalidone. I didn't mention this, but in the HDFP study, the main therapy also was chlorothalidone at 100 milligrams a day, or that was the target dose. In this case, it was 25 milligrams a day. And I'm not going to show the data, but that was based on a study that Dr. Matterson led that showed that 25 milligrams of chlorothalidone was the optimal dose of chlorothalidone. If you go above that, you don't get any greater blood pressure benefit, but you get more biochemical effects. And so ever since then, and that was actually, I think, in 1978, Barry, wasn't it? So ever since then, all of the guidelines have said that 25 milligrams or 12.5 to 25 milligrams is the appropriate dose for chlorothalidone. And so that's what was used in the SHEP study. The duration of the study was 4.5 years. They got a good separation in blood pressure, about 12 millimeters of mercury, and you can see that the treated group got in the low 140s, the placebo group in the mid 150s, and to some degree, the guidelines continuing to recommend 140 was based on the fact that these blood pressures were close to 140, but realized that was not the goal. The goal was actually about 150. It's a more complex goal, but essentially it's 150. So you can see that the diastolics in the treated group actually went quite low without adverse effect. And the primary outcome was stroke, and it was a reduction of 37%, highly significant. Interestingly, even with that p-value, it was not stopped early because the DSMB, who was monitoring this, didn't really see it cross the appropriate thresholds until really the end of the study. And so not only, though, was stroke reduced, which was the primary outcome, but also coronary heart disease, heart failure by over 50%, cardiovascular disease in general, and there was a trend for mortality to be reduced, but realized that studies like this, unlike HDFP, this study was not designed to be large enough to look at mortality as the primary endpoint. But if you put this together with one or two other studies that also tested similar systolic blood pressure goals, even mortality is benefited. Now, after SHEP, even though guidelines before SHEP, as I mentioned earlier, were recommending a systolic goal of less than 140, after SHEP, they continued to recommend a goal of less than 140. Again, the blood pressures were, on average, were close to 140, but the goal was really 150. And that's why a few years ago, in 2014, there were, based on the fact that SHEP, CISURE, and HIVET, these three major studies with goals of essentially 150, the guidelines actually recommended less than 150 in the JNC8 panel, and actually the last several VA Department of Defense guidelines recommended 150. That was very controversial because the guidelines had already been always been recommending 140, and now all of a sudden we're saying 150 for people over age 60. But the point was that that's what the evidence at that point was really pointing to. There were a couple studies that I won't show you that did test 140 as a goal, but none of them showed benefit. It turned out that they were grossly underpowered. They were done in Japan, and they had far fewer events than they expected, and so they just couldn't definitively get an answer. So we really have not had a study that specifically looked at 140. However, as you'll see in a minute, that's become a moot issue because of the SPRINT trial. So in the meantime, we were also trying to figure out whether it made any difference which drugs you use. And so one of the important studies that gave us a lot of information about this was the study that Dr. Matterson chaired and that I was the unofficial co-chair, I guess, of. But the VA, we called it the VA monotherapy study, but New England Journal didn't like that term, so it was changed to the VA single drug therapy study. So that's what we've called it ever since 1993 when it was published. And what we basically looked at here was not outcomes in terms of cardiovascular outcomes, but we wanted to look at whether, in fact, there were differences between the major drug classes that we were using as monotherapy or initial therapy for hypertension back in the 1980s, and whether there was any difference in overall blood pressure control. And again, we were looking at diastolic blood pressures here at that time, since there were no definitive outcome studies for systolic blood pressure yet. And in addition to that, were there other things that might predict who should get some of one drug versus another? And I won't belabor this except that to point out a little bit about the doses. The hydrochlorothiazide target dose was 50 milligrams. And I don't have time to develop that further, but if you look at the last several guidelines, ACCHA and JNCs, in terms of blood pressure recommendations, they all say that hydrochlorothiazide 50 milligrams should be the appropriate target dose. And the main reason for that is that we don't have any outcome studies that have used a lower dose than 50 milligrams as the target dose and shown benefit for hydrochlorothiazide, whereas we have good studies showing 50 milligrams is effective at reducing events. We have some with bigger studies, bigger doses. The VA study that I mentioned that we used 100 milligrams, but similar to the study that Barry led with chlorthalidone, we did a similar study in the VA that I believe you were chair of in the elderly, 213, where we compared 50 to 100 of hydrochlorothiazide and showed similar kind of things, that 100 milligrams was no more effective at reducing blood pressure and caused more biochemical effects. And so 50 milligrams is probably the right dose, at least target dose for hydrochlorothiazide. Atenolol 100, captopril 50 twice a day, clonidine 0.3 twice a day, diltiazem 180 milligrams twice a day, and then prazosin 10 milligrams twice a day. So at that time, there were not long-acting drugs in these last three, or actually four categories, even for the ACE inhibitor. And so what we looked at is 1 year control. So how many people could be controlled diastolic blood pressure-wise and stay controlled over a period of a year. And I'm not going to show the overall results. There were some differences, but the most important thing, and this really did have a major impact on how we approach therapy and what guidelines have said, is that there were differences looking at age and race. We looked at other things, a lot of other things, whether it made a difference, and it didn't by and large. And so you can see here that there are some differences when you are using only one drug. For example, in younger blacks, the calcium blocker is clearly the most effective. In older blacks, calcium blocker and then diuretic are the most effective, even though, again, the calcium blocker is more effective. In younger whites, any of the drugs worked okay, except hydrochlorothiazide, the diuretic, was actually less effective. Now that does introduce a little bit of a dilemma, because in younger people, the only classes of drugs that have been tested in morbidity and mortality outcome studies in hypertension are diuretics or beta blockers. And the diuretics were extremely successful, as in HDFP and the VA study, at reducing morbidity and mortality. But it does mean that you're often going to need to add other drugs to the diuretic. And then in older whites, all of the drugs worked fairly well, even though the ACE inhibitor was a little bit less effective, but not significantly different, which is what these lines mean. So there were different. We looked at a lot of other things. One of the most dramatic differences we saw is where you lived. And so if you lived in the southeast, not counting Miami, but if you lived in North Florida over to Texas maybe, and up to Virginia, you lived in the stroke belt. And so the stroke belt, we found that 4 of these drugs were clearly less effective. The diuretic, the beta blocker, the ACE inhibitor, and the clonidine were less effective in people that lived in the southeast or the stroke belt. And our belief is that it has a lot to do with diet and not with anything genetic at all. And so that we eat a lot more salt, even probably less potassium, and so that does make some differences. Now, what we also did in this study was those who were not controlled on the first or second drug they were randomized to, we combined those 2 drugs. They weren't huge groups, but they really did give us some important information. First of all, that once you start combining several of these drug classes, then most of these differences in age and race and where you lived go out the window. So if you combine a diuretic with an ACE inhibitor or an ARB, not in this study, but other studies, or a beta blocker, then blacks, whites, older, younger, all respond fairly well. If you combine a calcium blocker with a RAS blocker, the differences pretty much go out the window. And I think this illustrates the fact that the most important drug most of the time to be in that combination is the diuretic. And this just shows one example where the hydrochlorothiazide combined with anything else was more effective than any combinations that did not include the diuretic. And so certainly if you start with 1 or 2 drugs and blood pressure is still not controlled, then diuretic is the best thing to add if it can be. What we also found, and this is not the only study to show this, but that unlike a lot of the kind of popular opinion out there, is that, first of all 4 of the major classes that have been generally recommended in recent guidelines, a RAS blocker, beta blocker, calcium blocker, and diuretic, were all well tolerated compared to the clonidine or the alpha blocker, for example, in this case. If anything, there was a trend for the hydrochlorothiazide to be best tolerated. And I'm not going to show you the data, but in the all-hat study, that we'll look at a little bit of data in just a second, it turns out that the chlorthalidone was actually better tolerated. And it was a much larger study, so we could see the differences statistically better tolerated the amlodipine or the lisinopril ACE inhibitor. Now, the amlodipine probably was the edema that took people off of it. The lisinopril was probably cough. ARB would probably be, and it has been in smaller studies, as well tolerated as the diuretic. But I just want to point that out because there's drugs that have been around a real long time sometimes get a bad rap. And I think that's part of the problem with the diuretics, is they really are generally well tolerated by most patients. Now, so the VA single drug therapy study really did inform the ALLHAT study. ALLHAT was a large National Heart, Lung, and Blood Institute study that looked at major cardiovascular outcomes in 42,000 people, comparing the thiazide like diuretic chlorthalidone up to 25 milligrams, the calcium blocker amlodipine up to 10, lisinopril up to 40 milligrams, or doxazosin up to 8 milligrams. Now, doxazosin can be treated, if you look in the PDR, it says you can use 16 milligrams, but the people that donated doxazosin, Pfizer, actually didn't want us to use 16 milligrams because they knew it had a whole lot more side effects. It still had more side effects even at the 8 milligram dose. I'm not going to show you the doxazosin versus chlorthalidone results. Each of these were compared to chlorthalidone. That's why the sample sizes are different. Doxazosin was worse. It wasn't horrible, but it was bad enough that it was stopped early because it clearly was worse than the other three drugs in preventing particularly heart failure and stroke and overall cardiovascular events. And so that was stopped early. And then here are the main results for the amlodipine and lisinopril comparisons with chlorthalidone. We did a post hoc comparison of amlodipine versus lisinopril, and I'll be glad to comment on that later, but I won't show that here because this is the primary results of the study. Amlodipine, you may remember that back in the 1980s, 1990s, there was actually a lot of epidemiologic data suggesting that calcium blockers may be harmful. They may be killing people more often, they may be causing cancer, they may be doing other things. And in fact, what we saw is that the calcium blocker did pretty well. It did just as well as the other drugs, and except for one thing, it did not prevent heart failure as well as the diuretic. Now, compared to the ACE inhibitor, the amlodipine, they were pretty equal overall for cardiovascular events. The ACE inhibitor prevented heart failure a little bit better. The calcium blocker prevented stroke a little bit better, but they were otherwise pretty similar. But the heart failure was about 40% higher with the amlodipine than the diuretic. And then the ACE inhibitor diuretic comparison, this was very surprising to us at the time, even though there were some similarities in cardiovascular, all-cause mortality and coronary events, stroke, combined cardiovascular disease, and heart failure were worse with the ACE inhibitor. Now, the heart failure wasn't nearly as bad as the calcium channel blocker, but there clearly were these differences that favored the chlorthalidone and no outcomes that favored the ACE inhibitor. Now, these aren't huge differences, but they're statistically significant, and there are some differences here. When we looked at all the subgroups, and we looked at a whole bunch of subgroups, diabetics, older, younger, men, women, smokers, cardiovascular disease, really the only subgroup where there was some heterogeneity was comparing blacks to non-blacks. And so if you look here in the black patients, there was a much greater difference where the ACE inhibitor was much worse than the diuretic. And also, if you looked at it compared to the calcium blocker, it was worse than the calcium blocker. And for that reason, guidelines have consistently over the past several iterations, even in Europe, said that black patients should be started on either a diuretic or a calcium blocker as initial therapy, even though ACE inhibitors and ARBs can certainly be added to the regimen, unless there's a strong indication for the RAS blocker. And even then, we should consider adding a diuretic or a calcium blocker, like in somebody with nephropathy who needs the RAS blocker. Now, so after ALLHAT, JNC7 in 2003, which Dr. Matterson and I were both parts of that executive committee, and the VA Department of Defense guidelines, the last several iterations of them, including the 2014 guidelines, have recommended thiazide-type diuretics to be used for most patients with uncomplicated hypertension, either alone or combined with other classes. And of course, most of these guidelines do recommend that we start a lot of people on more than one drug. The JNC8 panel, which I was a part of, and the 2017 ACC-AHA guidelines, which I was not a part of, do both acknowledge the benefits of diuretics. I would have, for JNC8, I would have given a stronger recommendation, and they both recognize the benefits, but then say, but for overall cardiovascular outcomes and for mortality, at least in non-blacks, the four classes, diuretics, ACE inhibitors, ARBs, and calcium blockers, are probably not that much different. And so they do recommend those as initial therapy, even though I think it's important for us to keep in mind the additional benefits of the diuretic, particularly when we start combining with other drugs. And then, again, in blacks, there is a difference. Now, NHLBI then, after ALLHAT, the next large study that involved hypertension treatment was the ACCORD trial. Action to control cardiovascular risk and diabetes. And I brought in ALLHAT, I brought in actually 70 VA sites from around the country, and we had a much smaller number, but we're a part of the ACCORD trial, a significant part of the ACCORD trial too. And in ACCORD, we compared two levels of glycemic control, and I won't show that data. That's where there was actually an increased mortality for those in the intensive glycemia control with an A1C less than 6 compared to standard, which was 7 to 8 A1C. And then there was a lipid part of the study that tested a fibrate on top of a statin, and then the blood pressure was comparing 120 systolic to 140 systolic. And you'll see that that carried over in the SPRINT trial as well. We got a very nice separation in blood pressures, about 14 millimeters mercury difference, with the intensive group being about 119 and the standard group being about 135. And despite that, we didn't, and that was in almost 5,000 individuals, we did not see a significant difference in the primary outcome for the overall blood pressure study. There was about a 12% reduction in cardiovascular events, but it wasn't statistically significant. We did, however, see a significant 40% reduction in stroke. And so there was a trend otherwise. So we couldn't, and I'm going to come back to some other data on ACCORD in a minute, but certainly after that, most guidelines then kind of backed off the intensity of recommendations for diabetes. Previously, diabetics were recommended to be treated to 130 systolic, and then after the ACCORD trial and several other trials said, well, we really don't have the definitive data. The UKPDS study, even years earlier, had tested blood pressure and showed benefit in diabetics, but it was for a systolic goal of less than 150, and so much higher than the 130 or 140. So in SPRINT, we didn't include diabetics because that was still in the process of being tested in the ACCORD trial, but we looked at non-diabetics, but people at high risk with hypertension, and we looked at whether the composite cardiovascular event rate would be lower in people randomized to a systolic goal of 120 versus 140. In the primary outcome, we expanded a little bit from ACCORD. I didn't go into detail on what it was in ACCORD, but we included heart failure and acute coronary syndrome in addition to MI, stroke, or death. Similar to ACCORD, we saw a very nice separation in blood pressure with a difference of close to 14 millimeters of mercury on average. And as you may know, in 2015, we published the results that there was a 25% reduction in the primary MACE outcome, and the study was actually stopped early. After a little over 3 years, it was going to be a 5-year study because this was so dramatically beneficial. And even equally important was that all-cause mortality was reduced by 27%, again, highly statistically significant. Just a few months ago, we published the cognition results from the SPRINT trial, the MIND study, and we did not quite achieve significance for this 17% reduction in the incidence of dementia, and it does appear that it may well be real, but it's not quite significant. What we did see, however, was the usual precursor. Not everybody with this goes on to dementia, but mild cognitive impairment is what everybody who develops dementia goes through at some point. And so mild cognitive impairment was significantly reduced with the intensive blood pressure control. And if you combine mild cognitive impairment and dementia, it too is significantly reduced. Now, we're continuing to follow these people and to look at whether the treatment during the SPRINT trial will make a difference long-term in dementia, but we don't have that answer right now. And it probably would be unethical, at least in the United States, to do the same study over again because of the dramatic benefit for mortality and cardiovascular events for that goal of 120. Now, I think I'm going to just mention this very briefly. It's a complicated slide, but what it basically says, and I wanted to mention this because there's a lot of controversy and even some recommendations out there that when you treat systolic blood pressure to whatever goal, whether it's 120 or 130 or whatever, that not to let the diastolic go below 60. And that's based on post hoc or epidemiologic data. So what we did in SPRINT was we looked at the quintiles of diastolic blood pressures, and those with the lowest quintile, on the left there, at 61 millimeters of mercury coming in, those were also the ones that had the lowest diastolic blood pressures on treatment. And the bottom line is that there was no heterogeneity, that the cardiovascular events were reduced just as well in those in this lowest quintile who ended up with the lowest diastolic blood pressures as those across the other quintiles. So you do see a, quote, U curve or J curve of increased risk for the people that had these lowest diastolic blood pressures up here. But it just means they're higher risk and not that they're not benefited from treating the systolic blood pressure even if the diastolic goes down lower. So that's one of my sermons for today. So the implications of SPRINT for hypertension treatment guidelines, both the Canadian and Australian guidelines did recommend the goal that we used in SPRINT of 120 millimeters of mercury in certain high-risk people. The 2017 ACP AAFP guidelines did not recommend a lower goal. They don't really explain why. And we've even I wrote a letter to the editor. They still didn't come back with a definitive answer, but they kept on recommending the 150. And the only argument that you could come up with is, well, SPRINT is one study. But actually, if you do meta-analyses, which the ACC-AHA guideline did, even without SPRINT, it still supports lower goals. In this case, they decided to go with 130, both because the meta-analyses supported 130 as a goal, since there's only one study at 120, or two, I guess, counting ACCORD, but ACCORD and SPRINT, and also because they were concerned that because most people measure blood pressure improperly, and it usually overestimates blood pressure, that this would give a little bit of a safety room. But I think it's important for us to remember that in SPRINT, the goal we actually did, especially if you're measuring blood pressure correctly, was 120. Now, I think for time, I'm going to say this very quickly, but when you go back and look at the ACCORD data, it turns out that there's a difference between the outcomes in the standard glycemia arm, which presumably is what we're predominantly using today, the 7 to 8 A1C, and the intensive arm. So the intensive arm did not see a benefit for the blood pressure intervention, and that was the arm that had a higher mortality with the intensive glucose control. But what we did see is a very similar picture between the standard glycemia subgroup, blood pressure reduction in ACCORD, and the SPRINT results. And that's what this shows. So a 25% reduction in SPRINT and a 23% reduction in ACCORD. And then we looked at this more carefully, and I'm going to skip over to this. And if you look at the hazard ratios, here's SPRINT, there's a hazard ratio and a confidence interval, and here's the ACCORD standard glycemia arm. And you can see that they're almost identical looking. And so based on this kind of analysis, this particular paper wasn't necessarily published when when guidelines were looking at this, but based on this, most people then have extrapolated what we found in SPRINT to diabetics and recommended lower blood pressure goals in diabetics once again. And I actually agree with that. even though it is not based on the strongest level of evidence. So if a cord overall had shown benefit, that would have been great, but it didn't. So we do need more trials, and fortunately there are other trials going on. There's a study I'm actually on the Data and Safety Monitoring Board for in China that's going on, looking at these same goals in a diabetic population. And I believe there's also one in Brazil that's starting up looking at that. So this is part of the reason, or this concept is why guidelines are now once again recommending lower blood pressure goals for diabetics, even though we have to realize it's not based on quite as strong of evidence as it is for the sprint population. Now, one other thing I want to mention here out of sprint that has to do with diabetes is that we did have a pre-diabetic population. And basically what this shows is that those with prediabetes in sprint had as much benefit as those with totally normal glucoses. So it doesn't suggest that there's some aspect of glucose that makes blood pressure control less effective. And matter of fact, across most studies, you look at ALHET, you look at SHEP, you look at HDFP, all of those studies show just as much or more benefit for people with diabetes than those without diabetes for either lowering blood pressure to a certain goal or even which drugs we use. So the guidelines then are now going back to recommending lower levels, at least in most guidelines for people with diabetes. Final thing I want to mention is that fortunately in my old age I'm able to chair another VA cooperative study. It's called the Diuretic Comparison Project, VA Cooperative Study 597. For those of you that memorize cooperative study numbers, and Barry's probably the only one that has. But so what we're doing here is that there's been a controversy over time as to whether it makes a difference which diuretic you use. It's not, most other classes of drugs in hypertension, we don't have much. There's some controversy about ACE inhibitors or ARBs. But so here, there is some evidence from network meta-analyses, even though they've never been compared head-to-head, that the chlorthalidone may be better than hydrochlorothiazide. National Heart, Lung, and Blood Institute's trials have used chlorthalidone ever since the HDFP study, and for reasons that go back to the Mr. Fit study, and I don't have time to go into. VA studies, we typically used hydrochlorothiazide. And at least at higher doses, the hydrochlorothiazide seems to be pretty effective, but there are differences. I won't go into details here except to say that chlorthalidone lasts for 2 to 3 days, controls blood pressure much better overnight than once daily hydrochlorothiazide does. Maybe that makes a difference. There are other theoretical differences between the drugs that could make a difference. And so what we're doing is looking at whether, in a pragmatic study, whether the chlorthalidone lowers cardiovascular events more than hydrochlorothiazide. And we're doing it in the VA, and we're doing it open label. I won't go into details of it, but there's an article in the Annals of Internal Medicine a few years ago that discusses the theory behind this. But basically, we're comparing either 25 or 50 of hydrochlorothiazide that the patient is already on in clinical practice, and if they agree, randomize them to continue that or switch to half the dose of chlorthalidone. In 13,500 people, and we actually have recruited about 4,000 so far. All the management is done by the primary care providers. There are no local site investigators or coordinators. That would have cost $100 million to do the study that way, and nobody was willing to fund $100 million studies comparing two diuretics. And this is costing about $10 million. And so, in conclusion, the VA and the National Heart, Lung, and Blood Institute have really done some of the seminal work, some of the most important studies in the management of hypertension, and have really been the primary thrust for most recommendations and most treatment guidelines over the years, even guidelines from Europe and other parts of the world. Doesn't mean there aren't other important studies, there are, but very often they're Me Too studies after NHLBI or VA has done them. Hopefully, they'll continue, and we'll get answers to more questions as time goes on. So again, I'm extremely honored to be here and to be invited to be the inaugural lecturer for the Matterson Endowed Lectureship for Grand Rounds here, and I appreciate your attention.
Thank you, Dr. Cushman. I hope you have time for a few questions.
All right.
Yes.
I have a question.
Oh, okay. Yes, Dr. Clark.
Where do you obtain chlorothalidone 12.5 milligram tablets?
Yeah.
Canadian pharmacy?
Yeah.
Jupiter?
You cut the 25 milligrams in half, and it turns out that it's not hard for patients to do that if they have a good pill splitter. And so,
How frequent? When was the last time you attempted to do it?
yeah, we've actually done it with our patients. So ideally, and it's ridiculous that no company will make the 12.5 milligrams. Studies ever since Shep in the 1980s actually have used 12.5 to 25 of chlorothalidone. You can get the 12.5 in combination with one ARB, azilsartan. I'm not aware of, I don't think any other combinations of chlorothalidone. There aren't that many, but the atenolol chlorothalidone, I think, is 25 milligrams. You can cut it in half to get, if you got 100/25, to get 50/12.5. Yeah. So, and I'm not here necessarily to encourage you to switch everybody to chlorothalidone at this point. Wait till we finish the study to see whether there's an important difference. And one of the reasons for that is that there are so many combinations that do include hydrochlorothiazide and make it more practical and make patient adherence better to use the combination. Sorry.
How is the NIH and the NHBLI and the VA looking at the issue of genomics and how different race, social determinants of disease actually may play a role in these studies that hasn't been looked at before?
Yeah, I'm not involved directly in those, but there are a lot of studies going on looking at that. Probably in the VA, for example, there's the Million Veteran Program, and I think there's already over 700,000 of the veterans that have been recruited to that, and then so that will be a way to get a lot of outcome data within the VA, in addition to the genetic, the sampling and everything that's been done in that study. So when the patient agrees to it, then they get their samples drawn, and then they agree to have their records followed.
Professor Raj?
Thank you, Hugh. That was wonderful. You didn't talk anything about the most important organ, the kidney, right?
About what? I'm
The
sorry.
kidney, the most important organ.
Oh, the most important organ. I thought you said placebo. I said,
The problem, we have a problem with CKD, the CKD progression.
Yeah,
That needs to be mentioned.
yeah,
The fact is, after stage 3 of CKD, independent of the control of the blood pressure, provided that it's not, the tight control doesn't put a dent in it.
yeah.
That represents 30% of the budget of Medicare, okay, and it's $69 billion currently. What do we do?
Yeah, certainly Dr. Rai doesn't know anything about kidney disease and hypertension. He's
Just
a go-to
reword
expert.
The question.
Yeah. So where do we stand with intensive blood pressure control in kidney disease? Is that what your question basically was? Or how do we preserve kidney disease relative? Yeah, and certainly you can. From a Sprint perspective, I will say that we had a pretty large subgroup that we purposefully tried to over-recruit with chronic kidney disease in Sprint. And for that subgroup, we did see a similar benefit. If you look at the subgroup alone, it's not statistically significant, but there's no heterogeneity from the results. The results go in the same direction. That said, the lower the GFR, the less benefit there seems to be in Sprint. We just didn't have very many people with GFRs below 45. And so I think it lends itself to another study. And I know there have been several proposals, both to the VA and National Heart, Lung, and Blood Institute, to do a blood pressure goal study in patients with chronic kidney disease. The fact that they independently weren't benefited in Sprint, even though there's no heterogeneity, is a rationale for doing further studies in that. So I think that does need to be done. I will add that chlorothalidone actually works pretty well in patients with stage 3 chronic kidney disease. You can keep that in mind. So.
Dr. Matterson, can you come up to the front with Mrs. Matterson, and Dr. Preston, can you up to the front, please, now? On behalf of the Department of Medicine and in honor of this inaugural lecture that you gave, the Matterson Lecture, it's our privilege to present you as please come, Barry, why don't you give him the plaque, this memento of presenting this inaugural lecture. Thank you very much, Dr. Cushman.
Thank you all very much.
Thank you very much.
Wonderful to be here. Thank you very much. Yeah.
Dr. Weiss, can I take one?
Yes, please.
All right.
Wait a minute.
Wonderful. Okay. 1, 2, 3. Thank you so much.
Okay, thank you.